A 45-year-old post-operative patient suddenly develops breathlessness. His pulse is 128 beats per minute, blood pressure is 90 by 60 millimeter of mercury, oxygen saturation is 86% in room air. His ECG shows sinus tachycardia. Chest X-ray is almost normal. So, is it MI, sepsis or anxiety? Or are we missing something deadly? Hello viewers, I am Dr. Mukib presenting you a new video on pulmonary embolism. In this video, we'll learn about pulmonary embolism from its pathophysiology to diagnosis, risk stratification and life-saving management. Watch till the end for complete understanding. So, before we start, we have to understand what is pulmonary embolism. So, a pulmonary embolism is obstruction of the pulmonary arteries by a thrombus, usually originating from deep vein thrombosis (DVT) of the lower limbs. And most emboli originated from popliteal vein, femoral vein and iliac veins. And the most common cause of pulmonary embolism is thromboembolism. It occurs in 90% of the cases. And rare causes of pulmonary embolism are fat embolism, air embolism, amniotic fluid embolism, and tumor embolism. Let's understand the pathophysiology of pulmonary embolism, which is a very important part of this video. So let's understand what actually happens in pulmonary embolism. So when a clot blocks pulmonary circulation, the pulmonary vascular resistance increases, and then the right ventricle faces sudden pressure overload that leads to dilation of the right ventricle, and there will be decreased left ventricular filling, and then it will cause reduced cardiac output, which leads to hypotension and shock. And in gas exchange problem, VQ mismatch, V means ventilation and Q means perfusion, ventilation and perfusion mismatch, that leads to dead space ventilation, leads to hypoxemia. So in massive pulmonary embolism, there will be sudden cardiac arrest. Let's talk about the risk factors involved in pulmonary embolism. Think about Virchow's Triad. So according to Virchow's Triad, there will be stasis of blood flow. That means slow or stagnant blood flow increases clot risk, and it is seen in prolonged bed rest patient, long flights, heart failure, post-operative patients, and varicose veins. The second one is hypercoagulability. What is hypercoagulability? So hypercoagulability is the increased tendency of blood to get clots, and it is most often seen in pregnant lady or the lady who is taking oral contraceptive pills or any hormonal pills, the patient who is having cancer, the person who is suffering from dehydration, and if someone has inherited thrombophilia like factor V laden. So the next one is like, according to Virchow's Triad, the next one is endothelial injury. So the endothelial injury is like damage to the inner lining of blood vessels that promotes clot formation, and it is usually seen in trauma, surgery, and central venous catheters and atherosclerosis. So if we talk about the common clinical risk factors, so the patients who had recently underwent any surgery, they are having highly risk factors of DVT that leads to pulmonary embolism. Then prolonged immobilization, those who stays ICU for a long time, those who suffers from cancer, the lady who is pregnant or after the delivery, this is the postpartum period, they are also at a risk of having pulmonary embolism. Oral contraceptive pill that will also cause pulmonary embolism. So the lady who uses OCP are at high risk of having PE. Obesity is the most common cause, and if someone had previous DVT, deep vein thrombosis or pulmonary embolism, he is very prone to recurrent pulmonary embolism. Or someone who recently had any trauma like RTA or anything. And the most deadly cause of pulmonary embolism is smoking. So always ask your patient this, at least this much point in the history. Now let's understand the clinical features of pulmonary embolism. So classic Triad, like rarely all patient presents with dyspnea, chest pain, it will be like pleuritic chest pain, and hemoptysis will be there. And the most common presentations are like sudden onset of breathlessness. There will be tachycardia, tachypnea, hypoxia, and the severe cases, and in severe cases there will be syncope, there will be hypotension, there will be shock, and that leads to cardiac arrest. Remember one more thing, the chest x-ray may be normal in pulmonary embolism, so never ever be dependent on the chest x-ray report. So now what about the physical examination findings? So if you do the physical examination of the patient having pulmonary embolism, there will be like tachycardia, the JVP will be raised in massive pulmonary embolism, there will be loud P2, and the signs of DVT in the leg will be present, like varicose vein, and in late sign you will get hypotension. What about ECG findings? The most common, there will be sinus tachycardia. The classic but uncommon finding in ECG is like S1 Q3 T3 pattern, and other findings in ECG is right bundle branch block and T wave inversion in V1 to V4. There will be right axis deviation, and the ECG is supportive, not a diagnostic tool, so we cannot rely on ECG. So let's talk about the diagnostic approach. How we'll approach a pulmonary embolism patient to diagnose it. We'll talk about it step by step. So step 1, clinical probability. Use Wells score. If it's low probability, then go for D-dimer examination. And if the Wells score is high, I mean there is high probability, go directly for imaging. So we'll talk about what are the tests to do in imaging later on. Let's talk about the D-dimer. And D-dimer is very sensitive, but it is not specific. It may be comes positive in any venous thrombosis, not only pulmonary embolism. So it is helpful, the D-dimer is helpful to rule out pulmonary embolism in low risk patients, and if it is negative, pulmonary embolism is unlikely. So if positive, again imaging is required, must. So the step 3, the imaging, the gold standard diagnostic procedure for pulmonary embolism. So first and foremost, if you have that facility in your hospital or in your clinic, go for CT pulmonary angiography, shortly called as CTPA, and it shows filling defect in pulmonary arteries. In CTPA you will get like filling defects in pulmonary arteries. So if CTPA is not possible, what to do? VQ scan, ventilation and perfusion scan. So compression ultrasound of legs should be done. And step 4, the step 4 diagnostic criteria for pulmonary embolism is echocardiography. It is used in unstable patients, and mostly we can see right ventricular dilation, MC Cornell sign, and pulmonary hypertension in 2D echocardiography. So let's talk about the risk stratification of pulmonary embolism. First, pulmonary embolism is classified into massive pulmonary embolism, submassive pulmonary embolism, and low risk pulmonary embolism. So the risk stratification in massive pulmonary embolism is hypotension and shock and cardiac arrest. If there will be hypotension in the patient is shock, that will lead to cardiac arrest. And the risk stratification in submassive pulmonary embolism is like there will be normal blood pressure, but the right ventricular dysfunction will be present. RV dysfunction, right ventricular dysfunction will be there. And in low risk pulmonary embolism, the stratification is like the patient will be stable, no right ventricular strain. This classification guides treatment. Let's talk about the management of pulmonary embolism. So how will you manage a patient who is having pulmonary embolism? First, initial stabilization. We have to establish the patient before we go for any investigation or something else. First is oxygen therapy. We have to give oxygen. We have to do the IV access. We have to do cardiac monitoring. And remember one more thing, avoid excessive fluids in pulmonary embolism. It may cause the right ventricular failure. And if needed, we have to start vasopressors like noradrenaline if the patient is in shock. Then we have to go for anticoagulation, the main treatment. Start immediately if you are suspecting a patient of having pulmonary embolism and it is no contraindication. You can go for it, go for the treatment if you are suspecting the patient have a pulmonary embolism. So the options for Like anticoagulation therapy is like we can go for low molecular weight heparin, then we can go for unfractionated heparin, then DOACs like epixaben on or rivaroxaben. So how long we have to take the treatment, or we have to give the treatment for pulmonary embolism? So minimum of 3 months and longer if unprovoked. And let's talk about the thrombolysis. And thrombolysis is indicated in massive pulmonary embolism with persistent hypotension. The drug that is used in thrombolysis is alteplase drug. That is also used in like severe ischemic, any type of block in the cerebral artery. And this is a life-saving therapy. And we can also go for surgical or catheter embolectomy for failed thrombosis. If your thrombolysis treatment fails, then we have to go for surgical or catheter thrombolectomy. And contraindication to thrombolysis, and if the patient has any contraindication of thrombolysis, like he is already hypertensive and is on anticoagulants, or his PTINR is raised, his platelet count is low, in that case we cannot go for thrombolysis. In that case, to save the life of the patient, we have to go for surgical or catheter embolectomy. And the last one is like IVC filter. And IVC filter is indicated in patients who are contraindicated to anticoagulation therapy, or who had recently pulmonary embolism, or who is having recurrent pulmonary embolism despite of the therapy. So let's talk about the complications. So what are the complications that may arise in pulmonary embolism? The first and most common complication in pulmonary embolism is like recurrent pulmonary embolism. Then chronic thromboembolic pulmonary, hypertension, right ventricular failure, and sudden death. So how to prevent it? How will you prevent pulmonary embolism? Very important in hospital setup. So early mobilization of patient. If any of your patient are staying in ICU for a long time, or if any patient underwent any surgery, try to mobilize the patient as early as possible. And mainly in orthopedic cases, we have to be very careful about the lower limb surgeries. So DVT prophylaxis in surgical patients. In surgical patients, we have to give the DVT prophylaxis. Means after the surgery, we have to start the anticoagulation therapy. And if someone is at high risk of having pulmonary embolism, if any patient are at high risk of having pulmonary embolism after surgery or before surgery or anything, we have to start the low molecular weight heparin. There is no contraindications for this treatment. There we should use a pneumatic compression device to prevent it, and we should hydrate the patient properly to prevent pulmonary embolism in hospital setup. Now let's talk about the clinical PLs. So if a patient comes with sudden dyspnea with normal chest X-ray, think of pulmonary embolism. If any patient who recently underwent any kind of surgery, means if any post-operative patient presenting with unexplained tachycardia, then think of pulmonary embolism. If anyone come to your ER with history of syncope and hypoxia, rule out massive pulmonary embolism. And never wait for D-dimer in unstable patients. Never wait for it. Just start the treatment. So let's talk about the summary of the video. So pulmonary embolism is common, underdiagnosed, potentially fatal, but treatable if suspected early. Early recognition plus early anticoagulation saves life. So if you are a doctor working in ER, ICU, or the one who is preparing for exams, pulmonary embolism is a must-know emergency. If you found this video helpful, kindly like, share and subscribe for more complete clinical breakdowns. Comment below what topic you want next. Septic shock, ARDS, acute coronary syndrome, or DVT photo. Thank you so much. Thanks for watching.